Good afternoon and welcome to today's presentation. Dr. David Pintatori, Posttraumatic Stress Disorder and Medical Legal Reports. Before we begin our presentation today, I would like to take a few moments to review and highlight some of the necessary CLE tracking requirements as well as some updated information from WebEx. If you have logged into the presentation using Mozilla Firefox or Google Chrome, please use the following links on the screen to update your PC for future webinar presentations. Today, for CLE credits, for those of our attendees who require code words for tracking purposes, the code word for today is Ptsd. During the presentation, we will take short breaks, and during that time, we ask that you enter this code into the chat feature, which is located on the right-hand side of your screen right here, for CLE reporting purposes. The chat feature is located to the right, as I pointed out. Dr. Pintatori welcomes your questions, so please use this same chat feature to submit your questions throughout the presentation. We will take intermittent breaks so that Dr. Pintatori can respond. Tomorrow morning, we will send out an email with a link to an archived recording of this webinar. Also, before leaving the presentation today, we ask that you take time to fill out the survey that will appear on your screen after today's program. The survey is also a CLE requirement in some states. Our presenter today, like I said, is Dr. David Pintatori. He holds a Ph.D. in psychology from the Wright Institute in Berkeley, California. He is licensed in California, Hawaii, and Nevada. He has more than 20 years of experience providing clinical and forensic psychology, neuropsychology services, and conducting mental health research. In addition, he has 25 years in graduate education and administration. Dr. Pintatori is a member of the American Psychological Association and the National Academy of Neuropsychology. At this point, I'm going to turn the presentation over to Dr. Pintatori. And we hope you enjoy the presentation. And if you have any technical problems, please feel free to chat us anytime during the presentation, and we'll see what we can do. Dr. Pintatori, I'm going to give the presentation over to you now.
Thank you very much. As Brooke indicated, there will be time for questions midway through the presentation and at the end. First, I want to acknowledge permission has been granted to me by the American Psychiatric Association to provide in this presentation information on post-traumatic stress disorder, which is now published in the DSM-5. I also want to acknowledge these researchers and clinicians who I've relied upon in the course of preparing this presentation and who have informed my clinical work over the last 20 years. Perhaps some of them you are familiar with. Here's the presentation goals. Here's what I intend to present this afternoon. Given the topic, it's a daunting task, but I believe the subject matter deserves this level of attention. First, I want to briefly review how mental disorder diagnoses are made by professionals. Illustrate how post-traumatic stress disorder came to be established as a diagnosis. That is, note the gradual broadening in the criteria of the diagnosis. Provide some shorthand takeaways that attorneys can use in your practice regarding litigation of or defense against PTSD claims. 9/11. No picture illustrates more traumatic events and the human response to the trauma of terror. Perhaps some in attendance have experienced trauma themselves or know of family or friends who have done so. If that is the case, I hope this presentation has some personal usefulness. This picture could represent either of two attorney groups. A group of attorneys who have successfully litigated on a claim. Or it is a group of defense counselors who are pleased to hear that expert Dr. Jones was selected by the plaintiff, since he sees PTSD everywhere. This comment actually has importance in the selection of an expert. Plaintiff attorneys, in particular, want an unbiased expert and not an advocate in clients involving PTSD. The overall scheme of mental disorders in DSM-5 has not greatly changed. However, the manual does present an important caveat concerning the forensic use of the DSM-5. In particular, the diagnosis does not equal impairment, disability, or competency. The role of disability in the DSM does not equal disability in legal terms. Still, in DSM-5, these following characteristics are presented. There has to be some dysfunction in the person and in the processes that underlie mental functioning. These include physical processes, such as sleep functioning, which may be disrupted due to PTSD. The event is not merely an expectable or culturally sanctioned response to an event such as death. Let me talk about the epidemiology of PTSD. It is now a professional and scientific growth field, with over 15,000 scientific papers having been published on the topic in the last 40 years. It has its own journal, the Journal of Traumatic Stress. Recent military engagements have resulted in a large number of veterans with traumatic brain injuries, post-traumatic stress disorder, and other conditions. Treatment and disability claims will likely continue well into the future. Here's a picture of some Oakland Raiders fans going to the Coliseum to have some fun, with likely traumatic results for someone. Research has indicated that trauma and resultant post-traumatic stress disorder is more probable from crime rather than non-crime events. A brief review of the history of stress and post-traumatic stress. From antiquity, certain events were described in dramatic, singular terms in their capacity to alter the lives of humans. Writings from the Greek and Roman Empire have chronicled the powerful effects of war on the individual and their groups. Certain phrases illustrated the effects of war and other calamities on individuals. For example, soldier's heart, the phenomenon of soldier's heart in the Civil War era, shell shock in World War I, the image from the film Patton when the general berates two soldiers for their unwillingness to go back into combat. Freud coined the term traumatic neurosis to illustrate the impact of childhood sexual abuse on adult psychology. If we fast forward to World War II, Abraham Cardinger published a landmark study, The Traumatic Neuroses of War, and in it used the term physioneurosis to discuss the adverse effects of war and combat on individuals. In the DSM-1, published less than 10 years after World War II, the diagnosis of gross stress reaction was made. However, this diagnosis presumed that the person had a pre-event normal personality and that the stress would resolve over time. Since then, doctors have altered this concept of trauma. Gross stress reaction was dropped from DSM-2, published in the late 1960s. In the post-Vietnam War era, researchers and clinicians, such as Robert J. Lifton, understood that traumatic events led to psychopathology, rather than being due to factors such as bad character. A gradual link of events with subsequent trauma was underway. DSM-3 was crafted in the post-Vietnam era. With its publication in 1980, post-traumatic stress disorder made its appearance as a diagnosis that recognized the lasting pathological effects of traumatic stress. As the researcher and psychiatrist Eric Vermetten has noted, PTSD is a quote-unquote young disorder that started to be properly understood only from 1980. It was acknowledged that exposure to traumatic events could lead to long-term psychopathology. In short, the mental health establishment has, over the past 4 decades, altered its definition of PTSD from one of gross stress reactions to traumatic neuroses with a decidedly psychodynamic or Freudian meaning won the PTSD in the DSM-3 in 1980. With the publication of DSM-3 in 1980, a discrete event was noted to be the cardinal event. This opened the way for further litigation. Claimants could assert, based on subjective criteria, that one event was the cause of their distress and the reason for seeking damages. Regarding the courts, mention should be made of the gradual introduction of evidence over the last century of non-physical claims of distress. This trend was aided in part by the establishment of PTSD, which gave litigants a potential causal link between a presumed negligent event and the subsequent distress. Lastly, the Veterans Administration in 1980 ruled for the delivery of benefits to veterans with a delayed onset post-traumatic stress disorder. This opened the floodgates of potential claims for benefits. If the attendees don't mind, I'm making a bit of a link between traumatic events and pornography, which in my mind is similar to a $64 question. Simply put, will a jury be able to recognize PTSD in the course of a trial? What will be their decision? Perhaps more importantly, will an examiner know it when they see it? In this case, differential diagnosis is the key. Now, certain events may be traumatic, but the essence of a PTSD claim is that the event is lasting and has benefits, monetary and otherwise, are due to the claimant or victim. As I'll discuss below, this issue is central to the content of reports delivered by forensic examiners. The cardinal feature of PTSD is that, unlike all other mental disorders, it alone is based on the patient having experienced a particular event and re-experiencing that stressor with symptoms. This is what's called the conditional probability of PTSD that sets it apart from other diagnoses. The focus on a discrete event is what allows for the establishment of claims based on presumed PTSD. Furthermore, the trauma is defined by the mental health profession, not any other professional organization or institution. The exclusivity of mental health criteria for diagnosis does not necessarily flow to its exclusive role in the court. In the court, there remain the issues of accepted evidence, probative value, assignment of damages, opinion of the examiner. Talk about the epidemiology of PTSD for a few moments. Studies in the last 10 years, with both community samples and samples of population of interest, have found that trauma is commonplace. Research has offered evidence that traumatic events with lasting symptoms are commonplace, with nearly 9% of the U.S. population experiencing a traumatic event before age 75, and about 3% experiencing it in any 12-month period. Resnick's study of 20 years ago was an example of a study that was conducted over the telephone to assess for the prevalence of crime versus non-crime events. This study noted that the highest rate was found among crime victims. Norris's study found some differences among demographic groups, with young persons having the highest rates of PTSD. Perhaps many of you are familiar with the National Vietnam Veteran Readjustment Survey, conducted and published over 20 years ago. A particular note is that 30% of veterans had PTSD sporadically through a 2-decade period. What is also noteworthy about this study is that it anticipates what may occur in the courts following the wars of the last 10 years. Veterans remain the gold standard clinical population for research and treatment related to PTSD. Yet I believe that has important limitations regarding models of PTSD symptom presentation and recovery for the civilian population. Research on who is most likely to experience a traumatic event, not necessarily develop PTSD, but to experience a traumatic event, has found that males with a prior history of no college education, a history of conduct disorder in youth, and a history of family trauma, and have the trait of extroversion, that is, risk takers, go on to experience adult traumatic events. That is, prior history is a significant risk factor. In contrast, some research indicates that rates of developing PTSD, that is, developing the condition, may be higher in women with a family history of early separation, antisocial behavior, and the personality trait of quote-unquote neuroticism. This may be due to the development of a particular neurobiological vulnerability, or the unfortunate development of limited coping abilities and isolation and poor adaptation to a traumatic event. As noted from this particular published study, it's important to note that 50% of women who have been sexual assault victims are nonetheless symptom-free after 6 months. Both data on Vietnam veterans and assault victims highlight an important issue for attorneys and their examiners. To what extent do comorbid conditions or pre-existing conditions contribute to PTSD maintenance? First responders are also susceptible to conditions, but of note, the high percentage of patients who recover. That fact highlights the role of protective factors in eventually recovering from PTSD. I want to point out that this slide notes the concept of remission, and perhaps many of you have read that in medical records or reports and wonder what remission versus recovery means. Well, remission means that the patient no longer meets the full diagnostic criteria of a condition, in this case PTSD. There may be a reduction in the severity of all symptoms. There may be a slight change in one or more of them. Clinical question for the doctor or the examiner is, has the patient improved or not? Recovery, in contrast, means the patient no longer is in the diagnostic category of interest. Symptoms are present, but they no longer warrant the diagnosis. Motor vehicle accidents also have relatively high rates of post-traumatic stress disorder. Note that the rate of individuals who still have the condition 6 months after the accident is fairly high. Now, where does post-traumatic stress disorder come from? That is, what is the etiology? There's a genetic contribution. Research among veterans from Southeast Asia points to the contributory role of genetics in developing PTSD found in twin studies, such that both subjects, one of the twins who served in Southeast Asia and the other who did not, developed post-traumatic stress disorder in their lifetime. That is, all post-service events being equal, non-combat experience did not shield the person from eventually developing PTSD. Of course, the rates of PTSD were higher among those who served in combat in Southeast Asia than those who did not, but the important finding was that some percentage of the twins did develop the condition even without being engaged in combat. Genetic studies have also contributed to an emerging integrated hypothesis. High levels of early life trauma lead to a disorder, that is PTSD, due to the interaction of genes with brain neural circuits that regulate emotions, together mediating risk and resilience in adults. The brain can be transformed as a result of trauma. Research clearly points to how early life trauma, childhood physical or sexual abuse are predictors of PTSD later in life. Additional research has come to a consensus that family and community-wide factors increase the risk of childhood trauma. Numerous studies have consistently found a relationship between the psychopathology in parents and maladaptive responses in children, including PTSD. In the medical legal arena, this means that examiners need to, quote-unquote, look under the bed for evidence of early trauma. Risk factors include the following. Prior trauma, whether it exists or not, needs to be reviewed by the examiner. Prior psychiatric history, family psychiatric history. A particular significance is whether or not there is dissociation during the traumatic event. Of course, an examiner needs to conduct this portion of the assessment in such a manner as to not leave the patient with questions into providing certain data. For example, an examiner doesn't want to ask the question, you reacted with horror, did you, at the sight of your coworker's injury? Well, now we come to the centerpiece of the presentation. What are the changes in DSM-5 regarding post-traumatic stress disorder? With DSM-5, you do not have to have witnessed the event to possibly experience PTSD or warrant a diagnosis. The new criteria lists 4 specific exposure criteria which are listed in DSM-5 and include scenarios that involve first responders witnessing human remains, or what can be termed bystander disorders or aggrieved parents. The criteria are as follows. Directly experiencing the traumatic event. Witnessing in person the event as it occurred. Learning that the event occurred to a close family member. But in that case, it must have been violent or an accidental event. Experiencing repeated or extreme exposure to aversive details of the traumatic event, such as first responders having to examine and address human remains. But it doesn't mean exposure through the media or television. So in that regard, playing Call of Duty does not warrant a diagnosis of PTSD. It is also now a separate disorder termed stressor and trauma-related disorder. DSM-5 addresses what psychiatric researchers note as the criterion A problem. That is the actual definition of a psychological trauma. The mental health professions have moved from defining PTSD as an event that was once outside the range of human experience to a much broader range of events, such as serious injury, childhood exposure to inappropriate sexual acts, witnessing a deadly event, or even being informed of such an event. The aim of the new criteria is to enable doctors to make a diagnosis that reflects the results of research that notes how certain experiences generate trauma, and that the trauma results in a constellation of unique symptoms, as I noted earlier. Let's take a moment to review some of the criteria. The exposure criteria. Actual threatened death, serious injury, or sexual violence that involves one or more symptoms. A particular note in the medical legal arena is how is serious injury defined by the doctor. Intrusive symptoms. There has to be one or more from 5 particular criteria. Of note, intrusive symptoms must be recurrent, involuntary, and intrusive. That is, not voluntary, as in some depressive ruminations or obsessive conditions. There's the criteria of avoidance, which is persistent and deliberate avoidance of stimuli associated with the trauma. So it's called alterations in cognition and mood. A substantial number of symptoms need to be present here, 2 of 7, in order to warrant the diagnosis. And then marked arousal, 2 or more symptoms, such as irritability. Additional criteria that are present involve that the duration of disorder is more than 1 month. The diagnosis also provides information on risk or protective factors that need to be taken into consideration. For example, pre-traumatic factors, temperamental, environmental, or genetic. In the environmental realm, what was the extent of stability and safety to the person? Peri-traumatic factors, meaning factors at the time of the trauma, particularly environmental. How serious was the trauma? Did the person dissociate as a result of the trauma? And then what are called post-traumatic factors. Again, temperamental. Was the person resilient in the face of the trauma? Were they self-destructive in the face of the trauma? And then environmental. What level of support and non-support did the person receive? Forensic experts are required to address in their examination a full and detailed history of the plaintiff. Consider alternate diagnosis, and consider the role of secondary gain, or what's called malingering. What has been dropped from DSM-5 is the requirement for diagnosis of the person respond to the event with horror, fear, subjective distress. This criteria was found to result in a high percentage of false negative cases, meaning individuals individuals who had experienced a traumatic event were then evaluated by clinicians or researchers. They didn't report feeling horrified, and then they were misdiagnosed as not having PTSD when, upon later examination, they did meet the criteria. The emphasis is on the behavioral manifestations of the condition. But this doesn't mean that the patient or the examinee should be without emotion following the event. Claimants who in examination discuss witnessing a grotesque event or themselves experiencing a dangerous event without emotion, or with only limited evidence of post-event changes in behavior, may not be true PTSD patients. The elimination of criteria A1 does not put the claimant or the patient off the hook. There must be evidence of some symptoms. There are new childhood criteria for individuals under the age of 6 years and younger, and perhaps you would agree that that's a telling and distressing comment on our society, that children now are experiencing trauma to be diagnosed at such an early age. Fewer symptoms are needed to make the diagnosis. Inclusion of separate criteria for children highlights the role of a developmental perspective for children and adolescents. Among the findings relevant to the diagnosis is the role of attachment, connectedness between child and parent or caregiver, or loss of attention, and as this relates to the achievement of the child's safety and increasing self-efficacy, or the opposite due to traumatic experiences, excessive fear or excessive dependent behavior. Now, much more can be discussed on the unique features of PTSD in these groups, but time does not permit that overview. Please period a brief point of advice for both plaintiff and defense attorneys on child and adolescent cases. Both attorneys should realize that examination of very young children may not yield the evidence needed to make a diagnosis, let alone provide evidence for a claim of injury. That is often because young children may be hesitant to discuss or reveal their encounters with a strange doctor, even if he is supposed to be the expert. It's better to have the young plaintiff begin psychotherapy and have the psychotherapist serve as a source of evidence of the child's mental health condition. Now I'm going to move to the biological framework of PTSD. And we have here on the slide, this is the brain. Hopefully it's similar to everyone's brain here in attendance. 3 particular structures that I'm going to talk about. This is a lateral view with the frontal lobe on the right-hand side of the slide. The brainstem, as you can see, extending down into the lower left-hand corner. The occipital lobe in the far left corner. Substantial evidence from animal studies in populations exposed to chronic stress to brain structures, circuitry, and neurochemistry changes as a result of these events. The neurosciences have provided evidence of how the human brain responds to stressors in a manner different from that of non-stressor situations. However, attorneys should keep in mind that much of the research and clinical findings are based on either animal studies that look at basic brain functions, or populations that often are not the focus of civil litigation. That is, the published research has mostly been based in studies of combat veterans, women who are survivors of lengthy child abuse, or concentration camp survivors. I am not familiar with research that has given evidence of a significant changes in brain function as a result of a single traumatic event. But I'll briefly introduce the neurobiological model of fear processing as it relates to all conditions that might generate fear. First, information related to a threatening stimulus. You're being robbed by 2 men with knives in a dark alley. Enters the primary senses: sight, smell, touch, hearing. This potentially traumatic event has been integrated into coherent images in our brain, in our mind, that are grounded. That is, they're imprinted in time and space. This information is integrated in brain areas such as the amygdala, which you see in the lower central portion of the slide, or the frontal cortex. This event then activates memory traces of similar previous experiences with appropriate emotional valence, necessary in order to evaluate the true threat potential of the stimulus. Taken together, these subsequently trigger an appropriate motor response for the person. That is, flight, fight, or freeze. Specific brain circuits that mediate a person's responses make up the neurocircuitry of anxiety and fear. What occurs is the following. The critical brain structures that are found in the fear processing are the hippocampus, the amygdala, and the orbital frontal cortex. You can note from the slide where these brain structures are located. Particularly, the region known as the amygdala is the area that generates emotional experience. The hippocampus is where much of memory is located, and the frontal cortex is a judgment or reasoning center of the brain. Let's take a moment to understand the developmental trajectory of human fear and anxiety. Sensory information enters through our eyes and ears. For example, a car coming towards you at high speed with a person in the car screaming in front of you. This information is related to the areas of the brain that are designed to process such information, visual or auditory cortex. These brain areas then project that information to multiple other areas of the brain that are involved in mediating memory and emotion. For example, olfactory information has been found to project to the amygdala. Recall that the amygdala governs emotional experience. That is why certain people have adverse reactions to the smell of blood. The sensation is linked to the earlier emotive memory. Cognitive appraisal of potential threat is also an important aspect of the threat response. That is, we place the threatened object or person in space and time, recall the original traumatic event from memory, and then make a decision about the stimuli in front of us. For example, entering and noisy and crowded room may trigger prior memories of being assaulted with associated negative emotions and physical arousal. Let me briefly review the three brain structures that I've noted in their role in the processing of fear and arousal. The hippocampus has an important role in memory, and research has found that chronic stress can actually generate damage in its structure. The amygdala is involved in the memory for the emotional significance and intensity of events. It is also involved in generating conditioned fear and emotional responding, and governs peripheral stress responses. That is, increased heart rate and sweating. The frontal cortex, which region is involved in the regulation of emotional responsiveness, through inhibiting the amygdala. Thus, failure in this region may explain the emotional responses of persons with Ptsd and anxiety disorder. Fear and trauma also involve neurohormonal regulation. Among hormones, norepinephrine release to the brain represents an important part of the stress response. And for some reason, my slides are not, here we go. Oh, yeah, now we're moving. Excuse me. To understand the biological basis of PTSD, we must appreciate the underlying neurobiology of fear. It is processes that involve all fear responses, not just those associated with trauma. In particular, as Eric Vermenten has noted, a prolonged continuation of biological responses following stress, increased heart rate, release of hormones and opiates activating brain regions, may lead to an illogical pairing of the traumatic memory with the stress, cars coming toward you, and may then generate a cascade of secondary biological alterations. What is important to understand is that the brain is a key organ of regulation. The psychobiology of fear involves three particular characteristics: stress sensitization, alterations in brain function as a result of stress. That is, persons become wired for responses. Fear conditioning, immediate, unregulated, unwanted response to events with fear. Failure and extinction, difficulties in stopping or extinguishing the fear-related behaviors. And memory function, pairing the event in the present with whether seen or interpreted as similar events in the past. Let me conclude this section with two brief comments. There are two types of acute trauma responses that represent unique pathways to chronic stress-related psychopathology. One is primarily intrusive and hyper-aroused, increased heart rate, short of breath, and can be seen as a form of emotional undermodulation, that is, a totally postal type of person. The other type is primarily dissociative. There's no real increase in autonomic nervous system. It is a form of emotional overmodulation. That is, the guy who sits off in the corner. Now, persons may exhibit both types and may alternate between the two. This can serve as a useful overview on how to understand the results of chronic stress and trauma. Now I believe we're at the section of the presentation where I can take some questions.
Okay, great. We do have quite a few questions for you. We have a particular attendee who is representing a 15-year-old autistic boy who was involved in a pedestrian accident with his grandmother. His grandmother sustained significant physical injuries. The boy's physical injuries were not as significant, but since the accident, he's refused to have a physical exam. He was functional before the accident with some limitations, and since the accident, his paranoia has intensified. How can an autistic young adult be diagnosed with PTSD, and how can he be treated?
Well, let's focus on the treatment first. It sounds like this young boy unfortunately had symptoms of paranoia prior to the accident. I'm assuming that they were treated with medication. If they were not, then the first step would be for this young boy to be seen by a psychiatrist and either be prescribed medication for the first time or have the current medication revised. With respect to the physical exam, perhaps with the introduction of more or different medication, his agitation might decrease. It may also be beneficial for him to be present during the exam with a family member, the grandmother if she's able, or another family member to have him examined. That might reduce his anxiety. Certainly, in a case like this, there's a complex combination of symptoms related to the autism and potentially symptoms related to the post-traumatic stress disorder, but an examiner should be able to distinguish between the social withdrawal, the problems with social reasoning, the lack of affect in a person with autism versus the avoidance and the fear that might be related to post-traumatic stress.
Okay. Before we continue on with the next questions, at this time we do ask our participants to put in the CLE code that we asked for at the beginning of the presentation. So if you could do that in the chat feature at this time, that would be greatly appreciated. Thank you, everybody. Dr. Pintatore, related to that question, before we go on to the next one, apparently the young boy, he refuses to take medicine. He thinks he's going to be poisoned. Just so you know, they added that bit at the end of the question.
Okay. That makes it a little more difficult. Certainly, the most direct and vigorous route would be to provide the medication via injection. If the boy refused to take it orally himself, I would think that this young boy should be seen first in some form of intensive treatment to deal with the crisis, perhaps with the family members together to try to reduce his paranoia first in order for him to be receiving the treatment and evaluation that he needs.
Okay. Moving on to our next question. In personal injury litigation in which the plaintiff claims to exhibit symptoms characteristic of PTSD, is it possible to obtain a reliable independent medical examination or diagnostic test to determine the actual cause of these symptoms? Is a psychologist or counselor qualified to make such a diagnosis?
Yes, psychologists in particular. A counselor may or may not be based, I think it's based in part on the regulations in the states in which they practice. But certainly, as I'll talk in the second half of this presentation, I'll lay out the ingredients of a forensic assessment in such a claim.
Okay. I have another question here. Are there any general observations that could be made regarding the trauma experienced by victims of human rights violations, such as massacres, genocide, ethnic cleansing, etc.?
Yes, there are some general characteristics, and I know indirectly of many psychologists in the area that I work in who have evaluated such individuals, particularly from Latin America. And they would be a particular resource to serve in that regard. But certainly there would be a constellation of symptoms, perhaps consistent for people who've experienced that kind of trauma, particularly avoidance, hypervigilance, perhaps nightmares, secondary symptoms such as depression or anxiety. While I'm not familiar in great detail with the literature, I would be fairly confident that there's quite a bit of research published on the unique profiles of people who've suffered those kinds of events.
Okay. And one last question before we continue on. What is the intersection between PTSD and involuntary intoxication due to drug interaction to form a complete defense to charge?
Involuntary. Repeat the question again about involuntary intoxication?
Correct.
Well, I guess I'm not certain what it means by involuntary intoxication. Unless that means that somebody was unbeknownst injected with drugs or alcohol to drink when they were not conscious. I'm not certain about that relationship. Certainly there's a high degree of comorbidity, in part based on the severity of the post-traumatic stress disorder, but certainly problems with alcohol and drugs can, with some frequency, occur with individuals who have PTSD.
Okay, and part of that question was, does PTSD from a hypersensitivity to unintended drug interaction?
I'm not familiar with any research that indicates that the condition of post-traumatic stress leads to a hypersensitivity with drugs or drugs. I'm assuming that the questioner means illicit drugs as opposed to prescribed drugs. I'm not quite familiar with that.
Okay. That's all we have right now, so we'll continue on with the presentation.
Okay. So let's moving right along here. Slide from the previous portion of the presentation. Talking about differential diagnosis, there is no coincidence that in DSM-4, PTSD was listed in the anxiety disorders section. That is because the condition shares a number of the same symptoms as many anxiety disorders. Post-traumatic stress disorder also shares some symptoms of personality disorders. Listed here are 6 possible alternate conditions or diagnoses. 6, that may account for the patient's condition. As you can see from this table, many conditions share the same symptoms. 5 particular symptoms are illustrated as being in post-traumatic stress disorder. Similarly, individuals with panic disorder have 4 of the 5 symptoms, while individuals that have personality disorders, which I'll talk about in a moment, also share 3 of the 5 symptoms. Hence, given this complexity and similarity between disorders, the examiner needs to establish for all parties that a careful differential diagnosis is conducted. There should be, quote-unquote, no rush to judgment about the diagnosis. The examiner must determine the following alternate findings. The plaintiff suffers from another non-post-traumatic stress disorder diagnosis, such as panic disorder, depression. The plaintiff suffers from PTSD and another disorder, alcohol abuse, somatization disorder. Differential diagnosis is aided by the following characteristics which should be evident in an examiner's report. PTSD patients may avoid situations out of fear for safety for a return of an event, while paranoid patients avoid persons or situations out of delusional beliefs of harm. Depressed patients are overcome by guilt and present with psychomotor retardation, while post-traumatic stress disorder patients present with arousal. Patients with phobias, a condition that's listed here on the table, are fearful of a particular object that symbolizes something from their life: snakes, airplanes. That's not the case with persons with post-traumatic stress disorder. Persons with panic disorder are fearful of an event, situation, or person in the here and now. This is distinguished from the person with post-traumatic stress disorder who is reacting to an event in the past. Persons with flashbacks as a result of PTSD may experience quote-unquote voices, or they're felt the soldiers or the fallen family member. They're different from hallucinations. With the personality disorders, one key element is that the person's disorder, that is, their chronic, maladaptive way of relating to self and others, may be the key driver in the litigation. Persons with this condition fall into one of three descriptive types. First, there's what's called the dramatic, erratic person. They're over-emotional. They're vague in presentation. They have multiple physical complaints. They have little insight into their condition. What's called odd or peculiar type of individuals. They have very few relationships, little emotional experience. They have unusual beliefs about the world and other people. And then lastly, what's called manipulative or exploitative people. They're antisocial, psychopathic. They have little empathy for others. Careful review of the records, social history and examination can lead an opinion by an examiner regarding differential diagnosis. The doctor's summary in a report should include an explanation of how the diagnosis was arrived at, how alternate diagnoses were considered, rejected, or chosen. Some other characteristics of post-traumatic stress disorder relevant to litigation, what I'll call doctor delay and patient delay. Delay by doctors is easy to understand from a fact-finding perspective. The patient came in very infrequently over the course of a year to see their physician. And this suggests that medical records may not be sufficient as evidence. Patients may be very, very reluctant to discuss the matter with primary care doctors. There's also what I'll call the countertransference of the doctor. That is, the unconscious motivations within doctors, for example, primary care doctors, not to want to talk about things that appear to be overly emotional and very complex. They're not trained to do such an evaluation. They're not specialists in psychotherapy or psychological examination. They shy away from the condition. Delay by patients. Now, this may be less relevant in civil injury cases since the patient in effect becomes the plaintiff. But on some occasions, delay can be due to the person sinking themselves into work or family life for a period of time. There's also what's called complex PTSD. It's not an official diagnosis, but reflects persons with multiple overlapping and difficult symptoms, including somatic complaints, asphyxiation, vulnerable to repeated traumas, and in some unfortunate circumstances, even attachment to the perpetrator. Psychological assessment of the condition and litigation, a brief overview of the types of litigation that happens. Now, I'm not going to address the forensic issues related to the diagnosis of PTSD as a defense in diminished capacity, self-defense cases, or syndrome evidence. For the remainder of the presentation, I'll examine issues regarding workers' compensation claims, and in particular, personal injury claims. Statutes regarding causation in workers' compensation claims vary across states. In California, where I conduct the majority, but not all of my practice, the statute is highly restrictive. In fact, the passage of Bill 863 in January of this year instituted an elimination of awards of permanent disability for physical/mental claims, except under certain limited circumstances. Claims of post-traumatic stress disorder in the workers' compensation setting often involve a claim of quote-unquote sudden and extraordinary employment events that lead to the condition and associated impairments. In a physical mental claim, the physical injury leads to some sort of mental distress. that is depression or anxiety following the back injury or post-traumatic stress disorder secondary to traumatic brain injury. Physical mental claims appear to be the most straightforward. Physical component refers to instances where there is an injury and occupational disease which is found compensable. As a consequence of the initial disabling condition, the employee develops a mental condition that is itself further disabling. For a claimant to warrant a diagnosis of PTSD, physical injury, by definition, would have to have involved serious injury threatening death. A mental claim, of course, means that mental stress has resulted in a mental problem. These claims could warrant a diagnosis of PTSD as a result of witnessing a shooting as a transit worker, such as two cases in which I served as an examiner on in recent years. In mental physical cases, the key problem is often the causality issue. These claims can be problematic because of the need to prove that the condition, the physical condition, arose out of and in the course of employment. For example, cardiovascular disease as a result of stress on a job. It's a particular case that both examiners and attorneys who are involved in workers' compensation probably encounter. A woman who's at the department in a public service agency is threatened and files a claim for post-traumatic stress. You can take a moment to read the vignette. A number of questions can be raised and need to be answered in a case like this. What was the nature of the harm? How serious was the event? In the examination, how does the plaintiff react, or the claimant in this case, how does the claimant react in discussion with the examiner? What's the symptom presentation? The issue of differential diagnosis, really PTSD or perhaps one of the other conditions that I noted earlier. Is there secondary gain on the part of this claimant? That is he or she holding work conflicts that may not be resolved and has latched on to the issue of post-traumatic stress disorder? Can the person return to work after treatment? In that regard, what prevents them from sustaining the hardiness, given their long history on the job? Did the person have a genuine presentation or were there feigned symptoms? Now I'm going to talk about post-traumatic stress disorder and personal injury suits. What I like to think of, at least for examiners, there's many chapters and many verses. As many of you are well familiar, there's entire monographs and books have been published on this subject. I assume that the audience is well familiar with reports from forensic psychiatrists and psychologists regarding PTSD claims and personal injury cases. Some very basic legal principles still govern PTSD claims. I like to consider them as chapters of many verses. Causation in these cases can still be understood as divided into two parts. There's the factual cause related to the plaintiff. Were it not for the disastrous motor vehicle accident, PTSD would not have occurred in Ms. Torres. On the other hand, there's much clinical evidence to suggest that a PTSD claim or a misdiagnosis becomes an organizing fact in a person's life. It becomes a convenient medal to be worn as a way to avoid other personal issues. Then there's a proximate cause or legal cause. That is, legal duty to care. Liability for damages due to the fact that the squad system was not repaired as scheduled and Ms. Torres was seriously injured. In this regard, even if Ms. Torres had a prior history of domestic abuse, some portion of her current condition may still be liable for damages. Of course, in Chapter 2 regarding counsel, the defense has at its disposal the argument that the plaintiff was a supersensitive person. In other words, demonstrate that other evidence exists to account for her condition. In that regard, Ms. Torres jumps whenever the mouse enters the room. Third chapter involves the expert. Will the court allow the expert's report, including test results, to be entered as evidence? As I will discuss below, did the report meet a minimum standard for a forensic examination, and did it address all the new criteria for post-traumatic stress? For the defense attorneys, the most effective method to attack a PTSD claim is not to challenge the symptoms, but to suggest and ultimately prove or plant the question in the fact finder's mind that the defendant's actions did not bring about the symptoms. For instance, the symptoms are valid, they pre-existed as a less traumatic incident, or were caused by something other than the defendant's alleged negligence. For plaintiff attorneys, their most effective method should include obtaining an early assessment from the expert as to whether the case justifies the expenses of retaining them in the first place. And the expert produced a report that offers evidence of some injury amenable to damages, even if it is not post-traumatic stress disorder. Here for your review is one of the essential ingredients of a forensic examination, and I'll try to tailor it with respect to post-traumatic stress disorder. With respect to reports involving PTSD, the key ingredient linking them is a focus on evidence of pre-incident trauma or the absence of it, post-incident symptoms or the absence of them, and other post-event traumas, are they present or not. In some cases, neuropsychological evaluations may need to be conducted for prominent sensory, motor, and memory complaints. I like to encourage applicant attorneys to inform their clients to discuss fully their pre-event history with the examiner. It's more than likely it's going to be brought out at some point in the case. With respect to mental status examination and an assessment protocol, many examiners recommend that the only way to conduct a sound differential diagnosis is to use the SCID, which is the Structured Clinical Interview for the DSM system. It's a careful, comprehensive fashion to establish the sound differential diagnosis. This is a gold standard assessment that allows for differential diagnosis. Assessment can also include a specific structured interview, which exists to determine the presence of PTSD. With respect to this condition, the examination should be focused on whether the plaintiff meets the full criteria for PTSD or another condition. With respect to the assessment protocol, it should cover a range of measures. It can include MMPI-2 or some other measure to assess validity and general personality functioning. And offer a means to measure how the person is coping with the condition. MMPI in particular gives information on the symptoms and the person's adaptation or lack of adaptation to the symptoms. There are also specific instruments that allow for comparison of the person's complaints with known PTSD groups. Among them are the clinician-administered PTSD scale, which is a 25-item questionnaire given directly to the plaintiff. Prior trauma events may have been successfully coped with by the plaintiff, but the current event was different and perhaps more serious. Collateral discussions are routine, particularly for children, where information from teachers and coaches would be valuable to reinforce the clinical presentation. Interviews with persons who claim PTSD can be held on more than one date to obtain evidence of behavior in more than one instance. Then, at the end of the report, there should be a case formulation. It should establish a diagnosis relevant to the case or not. It should offer an opinion as to the relationship of the diagnosis to the events at hand. How does the person change by the event? How does the behavior fit the diagnosis? There should be an opinion as to causation and damages in the formulation. At best, the report should offer an opinion as to how the diagnosis of PTSD is related to the facts of the case, and to make a link between the plaintiff's behavior and what is known about the science of the condition. For example, that the plaintiff is so traumatized by the assault that they avoid at all costs a return to work in the warehouse or any similar environment, and that such behavior is consistent with the condition. It should include a trauma history, detailed history of whether there was any pre-existing traumatic events. There should be an assessment of the plaintiff's behavior versus the plaintiff's narrative on examination. A person who, their story describes a particularly harrowing or grotesque event or accident, but their presentation seems matter-of-fact, almost casual. The interview should be non-directed. There shouldn't be leading questions. Let me just briefly talk about some common errors in forensic examinations of these particular cases. The most important one, I think, is advocacy or bias. The examiner should not present themselves in an advocacy manner. They need to be an objective examiner. There should not be any bias one way or the other. I can truthfully say that I issued a report in a civil trial some years ago that was called into question by the defense as not being sufficiently objective and having taken the plaintiff too readily. And that was a lesson hard learned. There's another case, the second case, in a civil trial. This is perhaps a typical case example where the issues of pre-event trauma may be central to the issue of causation. You can take a moment to just read the case example. As noted, there may be two plaintiffs involved, the driver and the child. More than one expert is likely needed in such a case if damages are being sought from multiple parties in the case of gross negligence on the part of a trucking company. Now, in example, if permitted, obtaining the medical service records and employment records would be crucial to establishing the extent of possible trauma, if any, previously suffered by the veteran. Of course, looking at whether there's any premarital issues or marital complaints that might be contributing to the person's condition. Here's one of my heroes, Galileo, and he has been quoted to say something of relevance to examinations, PTSD claims, and the assessment of malingering. Galileo has said that all truths are easy to understand once they're discovered, but the point is to discover them. We talk about the phenomenon of malingering in examinations, particularly with respect to PTSD claims. Malingering is a difficult and treacherous diagnosis to make by the expert. It requires foolproof evidence that the person was non-credible for reasons of secondary gain. Often my approach is to indicate to the examinee that I'm going to be measuring effort and validity of their symptoms during the course of the lengthy exam. I say to them, do not try to exaggerate the extent of your challenges, such as not being able to add 2 plus 2. In cases of suspected performance, I may indicate that there's not sufficient evidence to make a diagnosis, but indicate that one is not there as well. Perhaps this is due to poor effort, inconsistent performance on the part of the plaintiff. But there are some common examples of what needs to be conducted in a malingering assessment, particularly with PTSD claims. The patient reports a suicidal ideation dramatically in the interview, but the event doesn't fit the behavior, or the suicidal ideation is without any depressive qualities. There's a self-report of memory problems, but memory assessment is adequate, or memory assessment results are highly exaggerated and not consistent with the condition. There's a self-report of sleep disturbance. They haven't slept in weeks, yet their office presentation is vital with a lot of energy. They don't yawn at all in a 6-hour exam. They give textbook definitions of the symptoms. Or alternately, they give very vague reporting of the symptoms. And then, of course, assessment or testing results might show exaggeration. I'm going to test your knowledge here. Since you have to get CLE credits, this is the test portion of the presentation. Testing your knowledge. First question. The MMPI team can diagnose the presence of PTSD in a claimant. True or false? I'm putting your answer now. False. MMPI clinical scales, in particular the PK or post-traumatic stress scale, measures anxiety or PTSD-ness related to a stressful event. But it does not have consistent predictive validity around PTSD. The scale
Hello? It appears we're having some sound issues here, so just bear with us. Hold on one moment. Again, we apologize for the technical difficulty. We seem to have lost our phone connection with Dr. Pintatori. I'll be getting back on the line with him. Just please be patient. We'll be right back. Thank you. Dr. Pintatori, if you can hear us, we lost your phone call. We need you to call back in. And we apologize again to our participants for the inconvenience. Please stand by. Good afternoon. We have Dr. Pintatori back on the line. We'll finish up the presentation. Thank you for your patience today.
Okay. So hopefully everybody can hear me. This is an indication that I'm somewhat obsessive, meaning that I persistently and obsessively was reading my notes and didn't even look at the slide presentation when Ms. Kinder told me that I was cut off. But at any rate, we're coming back up to, again, the test your knowledge. Self-report measures and reviews of the medical records can provide a diagnosis of post-traumatic stress disorder. True or false? You can provide your answer. False. As I indicated earlier, there's a number of both assessment instruments and then the structured clinical interview, which are really about to go in making a differential diagnosis. Psychotropic medication is the first line of treatment for post-traumatic stress disorder. This is not a leading question given the fact that I'm a psychologist. True or false? Both the Institute of Medicine in 2007 and the Department of Defense in their working guidelines a few years ago indicated that psychological therapies are the select line of treatment for post-traumatic stress disorder. Let's talk about treatment. Despite considerable research in psychiatry and the neurosciences on the biological factors that generate PTSD symptoms, the consensus professional opinion appears to remain that psychological therapies are the number one choice for treatment. Regarding pharmacological treatment, a recent review of the research conducted in 2012 suggests the treatment effect of medication is small. The effect that has been found is with the SSRI, antidepressant medication with fewer side effects. On that note, the Cochrane Group, an independent research evaluation organization, issued a review in 2007 of the literature that involved a meta-analysis of randomized controlled trials that considered well-defined psychological treatments to reduce these symptoms in comparison with a placebo, other control groups, that is usual care with a medical doctor or a wait list to study the effect of remission, or alternate psychological treatment conditions. 33 different trials fulfilled their inclusion criteria and were part of the meta-analysis. The results confirmed that particular and specific psychological treatments can more effectively reduce traumatic stress in individuals with PTSD than other treatments, usual medical care, or no care at all. In particular, what's called trauma-focused cognitive behavioral therapy, and what some of you may be familiar with as eye movement desensitization and reprocessing, that is EMDR, have the best evidence for efficacy at present, and they should be made available to PTSD sufferers. There are specific treatments that individuals who have a bona fide post-traumatic stress disorder condition should be referred to, not some form of open-ended psychotherapy with a counselor that is merely supportive. That's not the treatment of choice. There's also limited evidence that stress management, such as progressive muscle relaxation, is effective. These treatments are short in duration, often less than a year in length. An examiner should consider making that referral in the report if there's a question of a subsequent treatment. So that concludes my presentation. I'm happy to take a few more questions if individuals have.
We do have a question. Is it possible for a traumatic or stressful event to aggravate or trigger a pre-existing PTSD in remission caused by other previous events or life circumstances?
Yes.
Okay, and is it possible to differentiate between these possible underlying causes?
Well, it may be possible to differentiate between the underlying causes if in the initial event there's documentation of a discrete set of symptoms. And then there's evidence following the subsequent event that there's new and additional symptoms. But again, in those instances, they have to meet the diagnostic criteria, so there has to be symptoms that meet all of the four criteria for DSM-5 at present. There may be additional ones that have, unfortunately, been generated as a result of the recent event.
Okay. And we do have one more question, but in the interim, could the attendees please put in the code for the CLE that we asked for at the beginning of the presentation at this time? Thank you.
Here's my identifying information and my website for those who are interested.
Thank you. All right, we have one more question, Dr. Pingatore. If a plaintiff has a positive psychiatric history before a traumatic event, can a forensic expert offer an opinion that demonstrates a distinction between the pre-injury history and the current trauma?
Yes.
Okay.
I hope that the presentation has outlined the general approach that an examiner would need to take. If, for example, the pre-incident history was of depression, or a person was not eating, had suicidal ideation, worked sporadically, then they got treatment, their life improved, they went on for a number of years, and then they had the supposed or reported traumatic event with another set of symptoms. It would take careful examination, somewhat lengthy report, careful review of the records, perhaps collateral interviews, but certainly I believe a case can be made.
Okay. And one last question. Is it appropriate for a treater to also serve as a forensic expert at trial?
No.
Okay.
I hate to be so blunt, but no.
Okay. And we have somebody that said...
I'm not certain why the treater would want to put themselves in that position.
Okay. We do have one more question from Mr. Rappaport, who said he asked the question earlier, and we must have missed it. So I'm just going back to look for it for him to answer for you. Hold on one moment. Mr. Rappaport, if you could just type in the question that you'd like asked into the chat feature. At this time, I'll be more than happy to ask Dr. Pingitore for you. And Mr. Cohen, I didn't get your question as well. We do have a question. Were there increases in PTSD claims as a result of the mass shootings at the various schools over the past recent years?
I don't know of any published information on those. Again, I don't know which mass shootings you're talking about. Perhaps the one in Connecticut. Those may take a while to generate as various kinds of claims.
Okay. Mr. Rappaport asks, would PTSD victims be more likely to use marijuana?
More likely in comparison to who? There is evidence to suggest that they certainly use marijuana as a form of treatment to reduce anxiety.
Okay.
Then there's the and if that's the case, and they've been suffering from the condition for many years and have been using the marijuana heavily, then there's an alternate and secondary impact on their working memory. So then you have an additional problem, potentially, that they've got intermittent or possible working memory deficits as a result of the habitual and perhaps extensive marijuana use.
Okay, and we have one last question. Can prolonged daily emotional abuse lead to a diagnosis of PTSD?
Well, I would want to operationalize emotional abuse. Unlikely, unless it came with threats of physical harm or something worse. But such a condition, such as chronic emotional abuse, could certainly lead to any of a number of other painful problems, particularly with a child who then, gradually develop into an adolescent or adult, such as depression or anxiety or substance abuse. But, chronic verbal abuse in and of itself, unless it involves threats, wouldn't potentially create a diagnosis of a condition of PTSD.
Okay. Those are all the questions that we have for today. I'm going to take the presentation back over to Tassa as the host.
Thank you very much for attending. I hope that you found the information useful in all aspects of your life and work. Thank you.
Okay, thanks, Dr. Pingitore. We thank everybody again for attending today, and especially Dr. Pingitore. We'd like to remind you about the CLE information. This webinar is eligible for CLE credit in California, Illinois, Minnesota, Missouri, New Jersey, Pennsylvania, and Texas. And to ensure you receive your CLE credit, please make sure you complete the survey that comes up at the end of the presentation. The TACA group, in addition to being your best source for testifying and consulting experts, we also offer e-discovery and document management, free interactive webinars, and research reports on expert witnesses. Tomorrow, we will send out a link to an archived recording of this webinar, and the archived recording will also be posted in the Knowledge Center on TACA's website. If you have any follow-up questions or comments, please feel free to email Carol Kowaleski at her email address below. I want to take this opportunity again to thank everyone for attending, most especially Dr. Pingitore. We apologize for our technical difficulties today, and we appreciate your patience. If you would like to speak with Dr. Pingitore, or if you'd like to speak with a TACA representative regarding an expert witness for a case that you're working on, please be sure to call TACA at 1-800-523-2319. Thank you again. Have a good day.
Bye-bye.
Bye-bye.